خلاص تمام.
يعني نشوف
اوكي.
البار ده لو نمشيه شوية من الحتة دي. أيوه. ماشي being recorded. اوكي ماشي. اوكي
اي.
كده واضح شوية.
اه واضح كويس اوي.
طيب في الناحية التانية. طيب عموما شكرا على الاوبورتيونيتي والاستضافة، والنهارده هنتكلم على الابليشن اوف idiopathic ventricular tachycardia. آم، احنا اتكلمنا تقريبا على حاجة يعني similar to that قبل كده. disclosures. والobjectives بتاعتنا النهارده ان احنا نعرف indications of ablation of ventricular tachycardia، نعرف review the limitations of pharmacologic options for the treatment of idiopathic VT, و review the 12 lead EKG system and how to use it to localize events in the heart, and um, and develop some systematic approach to the localization of the site of origin of ventricular arrhythmias. We'll touch bases a little bit on the recommended power settings and the role of PFA, and the special sites of origin for ventricular arrhythmias, particularly idiopathic ventricular arrhythmias, and where to target them. I think for young electrophysiologists, one of the things that are very, very important for everybody to understand is the classification of ventricular tachycardia. دي حاجة مهمة جدا، وكونسبت لازم يعني ايه نفهمه شوية beyond conventional approaches. فاحنا لو حبينا ان احنا نقسم الفنتريكولار tachycardia، وده في hypothesis وفي assumptions، بس اذا حبينا نقسمها ل two different types: idiopathic VT و VT in structural heart disease. وبعدين حاولنا نعرف الديستنكشن demarcation ما بينهم. هنلاقي انه يعني لازم we have to realize that انه جزء كبير من الventricular tachycardia in structural heart disease can also be associated with a normal ejection fraction. So the ejection fraction is not the only thing that demarcates the difference between idiopathic VT and structural heart disease associated VT. That's actually a much deeper distinction. So structural heart disease VT can occur with a normal left ventricular ejection fraction and can occur with a reduced left ventricular ejection fraction. That can happen in both directions. Now, idiopathic VT usually happens in the presence of normal ejection fraction, but that's not the only condition to call something idiopathic VT. So how do you make the distinction between those two? This is a very important concept. Why? Because sometimes we end up having to implant defibrillators. These are some big decisions that need to be made. Not everybody who has VT needs a defibrillator. So how do you make the difference? Well, usually, and prognosis-wise, usually idiopathic VT is benign. It doesn't cause sudden cardiac death. And that's why these patients do not need defibrillators. Whereas structural heart disease VT is malignant, and those patients need defibrillators for protection. Well, how do you make that distinction, especially if you have someone with a normal ejection fraction? There are a lot of things we look at to tell the difference between idiopathic and malignant VT. Idiopathic VT doesn't cause sudden cardiac death, like we said, whereas structural heart disease associated VT causes sudden cardiac death. Normal cardiac structure in idiopathic VT, and in structural heart disease VT, remember, cardiac function can be completely normal, but cardiac structure is not complete. You can have someone with an inferior myocardial infarction and still normal left ventricular function. Okay, that's just a simple example. I mean, the echo might pick up on the wall motion abnormality. It might actually be a small basal inferior infarct, and echo might not see that. MRI is really the one of the key elements here. It's MRI, it's history, and it's the EKG. MRI is very helpful. MRI will show you scar, even if it's a small amount of scar, it's very, very significant. But in idiopathic VT, by definition, the MRI is going to be normal. Syncope or not, syncope, if associated VT, it's not benign. It is not normal heart. If there's loss of consciousness, usually patients with normal hearts tolerate VT, they don't pass out. And the major difference, like we said, is in terms of management, is who gets a defibrillator and who does not. Idiopathic VT arises from very predictable locations. It doesn't mean that structural heart disease VT cannot arise from these locations. It can, but things arising from these locations, along with other suggestive, features, make it more likely. It's idiopathic. It's AA. So outflow tract, right, left outflow tracts, the papillary muscle, and the Purkinje fibers. Things like that are more likely to be associated with idiopathic VT. It doesn't mean you cannot get structural heart disease VT arising from similar locations. Now, similar doesn't necessarily mean the same. So, for example, um, you can have non-ischemic cardiomyopathy with perivalvular fibrosis, and you can get ventricular tachycardia arising from the vicinity of the aortic valve. And that's not the same as an outflow tract VT, and that is idiopathic. They're different. Really hard is sometimes to put it into bullet points. It takes a little bit of experience and having been there, looking at the signals, where you're looking, if there are signals fractionated, you have late potentials, can sometimes happen in idiopathic VT. But if you have extensive late potentials, you have multiple QRS morphologies, multiple VT morphologies, all of that is more suggestive of structural heart disease VT. But this is very important, okay? That distinction between idiopathic and structural heart disease associated VT. And I'll give you an example here. This person can have totally normal echo, totally normal ejection fraction, sorry. So that can be completely normal. And they have VT, right? And you do an MRI and you find delayed enhancement, all these white markings there in the left ventricle. That delayed enhancement tells you there's scar here, and if there's scar, then it's not normal. And that person needs a defibrillator. And then when you do a PET scan, which is that on the right, you can see increased FDG uptake, which tells you that there's inflammation in this area, and that points to sarcoidosis. Now, this is somebody who had a completely normal left ventricular ejection fraction, and they might not have even had syncope. But you have to be able to look at the VT and say, well, something about this is not right. Let me get more information. Well, okay, so now we talked about the difference between those two. How do you manage idiopathic VT? Well, beta blockers, calcium channel blockers, you could try those, and escalate in doses until the patient feels better, symptoms are better, episode frequency goes down. At moderate doses mostly don't work. Sometimes you need high doses, which is really not convenient for patients. It causes side effects. Sometimes they feel worse. Sometimes you drop their blood pressure and they go into VT and now they feel much worse. Ablation is really the key treatment approach to idiopathic VT. The site of origin sometimes can be very challenging. Sometimes it's in an area you can't reach, but most of the time you can get rid of it. The recurrence rate is less than 5%, and the risk of complications is 1% or less in experienced hands. I'm showing you, an example of what's a very difficult site to reach. This is a case I did, and you can see the catheter sitting at the bifurcation of essentially across from the bifurcation of the left main. If the catheter is 4 millimeters and you're about 2 or 3.5 millimeters, you're about 5, 6 millimeters away from the bifurcation of the left main. This is a site that poses a lot of challenges. They're not always easy to get rid of. When do we go for ablation if they have symptoms and failed or declined medical therapy? Some patients just don't want to try. Generally speaking, after you ablate it, it is probably recommended to maintenance therapy with beta blockers or something of that nature. What agents do you go for? I want to caution you. I should have put that on the slide here. I want to caution you. Again, there's a lot of people do this, and I absolutely disagree with it. And so I want to caution you against the use of class 1C antiarrhythmic drugs in patients with VT. whether they have a defibrillator or not. Obviously, if they don't have a defibrillator, it's even worse. But whether they have a defibrillator or not, my advice to you, and a lot of people do this, a lot of experts do this, and it's wrong. In my opinion, it's completely wrong. I'd never do it. Do not use class 1C antiarrhythmic drugs for ventricular tachycardia, idiopathic or not, because you're never 100% sure. You can never be 100% sure. Okay. We have to make a decision and a distinction for the purpose of ICD implant, but there's always a chance that we could be wrong. And you can take a stable VT and give somebody flecainide and you make it incessant, you can make it faster, you can make it slower, you can cause sudden death. I have seen this before, structural heart disease, missed on echo. I saw a case where it was missed on MRI. Okay. And flecainide caused sudden death. Flecainide is not safe for patients with structural heart disease and ventricular tachycardia. This has been shown in multiple trials. So I'm talking about flecainide, propafenone. If you want to use an antiarrhythmic drug, you want to use a class 1 drug, use Mixility. It's mild. Just tell patients to take it with a meal. It doesn't bother the stomach, and it's tolerated okay. It may or may not work. If it doesn't work, if you want to add sotalol, you want to add dofetilide, you want to add, anything like that, that's fine. Amiodarone is crazy. I mean, idiopathic VT is easily ablatable. So using amiodarone for that is not, doesn't make any sense. Too much risk for very little gain. So that's what I want to say about antiarrhythmic drugs and the management of idiopathic VT. This is a fun one. This was a case of patient that had left ventricular summit PVC. We can probably talk about EKG and come back to this. I will probably come back and touch base on it later after we finish talking about the EKG. It might make a little bit more sense. So, okay, let's see where we're at with this. Okay. One of the most important things to really talk about with idiopathic VT is localization and knowing where to go and where to ablate. This is one of the key concepts. If you know where to go and where to ablate, it's a very easy problem to fix. If you don't know where to go, it can become a really difficult thing to do. And it is also a combination of two things. It is understanding the anatomy and understanding the EKG. This is one of the hardest things, and it really, in my opinion, is the crux of doing anything in terms of VT work, understanding the EKG. How do you make sense of it? You got to understand the anatomy of the right ventricle and the left ventricle. You got to understand how those two ventricles are related to each other and how they're related to the chest. And so structures, intracavitary structures, you got to be aware of them. The papillary muscles of the RV. Let me get that marker here so I can. So the anterior papillary muscle, the inferior papillary muscle, some people call it the posterior papillary muscle, and there is the moderate band. These structures in the right ventricle are very relevant, especially for idiopathic VT. Intracavitary structures, conduction system, valves. Idiopathic VT doesn't come from just the middle of the muscle. It always comes from very predictable areas. Predictable because they either have intracavitary structures where muscle interfaces with conduction system, or areas where muscle interfaces with connective tissue. So Frank Marshalinski would always say this. It's these idiopathic arrhythmias, even idiopathic atrial tachycardias. That's why we see it a lot on the tricuspid valve, at the mouth of the coronary sinus, yet certain structures. Why? Because there is an interface between muscle and connective tissue. This is connective tissue. This is muscle. So they come from these areas. They come from conduction system, and so these are very predictable areas. We got to keep an eye on that and think about what what you're looking at. Very helpful to tell if you're looking at an idiopathic VT or not. Okay, so to understand this, we need to understand the anatomy of the EKG system itself and the anatomy of the heart relative to that. And we talked about this with atrial arrhythmias, but you have to understand that any wavefront going towards an EKG lead is a positive deflection. Anything going away from an EKG lead is a negative deflection. You have to understand that V1 through V6 are called the precordial leads for a reason, because they surround the heart along the chest wall. V1 being most anterior, V2, 3, 4, 5, and 6 are moving posterior relative to the heart and lateral. And if and then the concept of the transition of the EKG transition or the precordial transition is very important. Where does the deflection turn from positive to negative or from negative to positive? That's very important. That tells us roughly how far we are relative to the EKG system itself. So V1, for example, is very close to the chest wall. Okay, so if we had something coming out of V1, it'll be very negative. V2 is less anterior. So V1 might start seeing a slightly positive deflection, right? Something is going towards V1 and then going away. I'm sorry, V1, yeah. So V1 would be slightly positive, but then the rest of the deflection would be negative because most of the heart mass is away. V3 would do just a little bit more because now you're adding the septal side of the RVOT to the amount of muscle between you and the lead. So the more muscle between the site of origin and a particular lead, the more positive deflection you have. The less muscle, the less and essentially more negative deflection you have. And so if we go to V3, that positive deflection becomes bigger. If we go to V4, that positive deflection in V1 becomes bigger. If we go to V5 or we're to position 5, now that deflection in V1 becomes really positive. What does that mean? It means that we're always going to have a left bundle pattern in V1, which means that the area under the curve, the majority of the area under the curve, the net deflection in V1 is going to always be negative until we reach the vicinity of the mitral valve. Okay? Why the mitral valve? Because the mitral valve is actually not left, it's posterior. Okay? The heart sitting in the chest, where the mitral valve is in the back of the ventricles. The most posterior thing in the ventricles is the mitral valve. So it's far away from V1. So then we get a right bundle deflection in V1. Essentially, rule of thumb is if you have a right bundle VT, okay, you start thinking we're on the mitral annulus, especially if there's no transition. Well, what does the transition mean? Transition means, what happens to V2, V3, V4, V5, V6? Well, we need to understand that. I have, let me go to this other presentation that's going to explain this a little bit more for us. I have to change the window we're sharing. Yep. So now you should be seeing the EKG localization window. Let's see if I can make it. Okay. كده شايفينه فول سكرين أحسن شوية؟ مظبوط؟
Yes.
Okay, good. All right. فدلوقتي هنتكلم على ال EKG localization, which is really, in my opinion, is really the most important thing. Idiopathic ventricular tachycardia is very easy to ablate. You have to be in the right spot. If you don't know where to go, if you do not know how to find the right spot, you're not going to be successful. Okay, it's usually coming from a very small site of origin, very few cells. Relative to the power of ablation tools that we have, it's like dropping an atomic bomb to kill a cockroach, but you have to be in the right spot. If you drop an atomic bomb in a different country, it's not going to kill a roach in a country that is, thousands of miles away. And so you got to be in the right spot for this to work. So we have to understand the basic ones. For example, the outflow tract. So let's understand the anatomy of the outflow tract. If we were to cut through the left ventricle, you would see the non-coronary cusp. Let me see if I can get that marker. Okay, so the non-coronary cusp, okay, left coronary cusp. Now notice something, the non-coronary cusp is lower than the left coronary cusp. They're both at the top of the ventricle. They're sitting on top of the entire ventricle. So if you looked from the inferior leads, they'll be positive, right? So those are positive deflections in the inferior leads. If you're in the left coronary cusp, right, lead 3 is sitting sort of here. Lead 2 is a little bit more to the left from there. And so lead 3 is very sensitive to anything that is low. So the right coronary cusp is a little lower than the left coronary cusp. Non-coronary cusp are also lower. So then we start looking at things that are positive in the inferior leads, but also have a slightly different ratio between leads 2 and 3. Lead 1 tells us if we're septal or not. If we're closer to the septum, lead 1 is going to be a positive. Lead 1 is going to start becoming negative once we cross the plane of the left coronary cusp, roughly. Some say the plane of the LED. I don't know. I think it's more, if you start getting to the left coronary cusp, lead 1 is not going to be positive anymore. It can be positive in the right coronary cusp for sure. So these are things we need to pay attention to. Okay. Let's see. Will allow me to. Okay. We talked about this, understanding the concept of the transition. We can also try to understand it now, incorporating not just V1, but incorporating all the other precordial leads. So now this is how V1 through V6 are arranged across the precordium. And you can see the right ventricle, which is right here, is very close to V1 and V2. So how much muscle is between V1 and V2 on the right ventricle? Not a whole lot. So then anything coming from the right ventricle is going to be always negative in V1 and V2, for example. Now, as soon as you start crossing into the left ventricle, now you're going to start moving away from V1, and then you start having more positive deflections in V1. And that's why a lot of VTs coming from the left ventricle will be right bundle VTs. Now, if we are on the mitral annulus, we're really hidden way back here. We're far away, okay? We're far away from all of these leads. There's so much muscle between you and V5, V6, V4, V3, V2, V1. So what does that mean? Positive concordance. What does that mean? It means that you're going to be right bundle and no negative transitions. You keep going positive throughout the precordium. And as you go down the ventricle, you go down the left ventricle towards the apex, you're going to start doing exact opposite. You're getting closer to V5 and V6, and at some point you're going to start becoming negative in those leads, but you're still positive in V1. If you move towards the septum, you could actually get too close to V1 to where you start having left bundle VTs. So the left ventricle gives you left bundle VTs, right bundle VTs. Right ventricle only gives you left bundle VTs. I've seen 2 cases of patients who had right bundle VTs arising from the left ventricle. I should have put in a paper, and both of them had the same exact thing. They had aneurysmal RV apex. The RV apex was over the left ventricle, and it was really strange to have a right bundle VT arising from the left ventricle. I've seen it twice, but that's not the rule. That's just an exception. So again, to put it into simple terms, anything arising from the LVOT is going to transition in V1 or V2. Anything arising from the RVOT will transition from V4 to V6. And why is that? You can see it. Parts of the LVOT, as you can see, is more posterior. So LVOT is sitting in the back, RVOT is sitting in the front. They're not left and right. In fact, the pulmonic valve is left of the aortic valve. Okay. But the main difference is what's anterior and what's posterior. The pulmonic valve is anterior, the aortic valve is posterior. And so the transition then becomes you get an earlier transition from negative to positive in the LVOT. You get a later transition from negative to positive in the RVOT because it's more anterior. And V2 seems to be a demarcation, and V4. Now, V3 is a problem. V3 is really hard to tell. If you are transitioning from negative to positive in V3, you don't know if you are in the RVOT or the LVOT. Again, all we're doing right now is we're trying to predict the site of origin so we can go to the right spot. Let's talk about the anatomy of the RVOT a little bit to kind of break it down. And so you can see that red line that splits the RVOT into free wall and septum. And then you got these green lines, they're split in the RVOT in different planes. And obviously, you know, a lot of people don't, again, you know, remember the LVOT is actually very leftward. The LVOT is actually can be very close to lead one. Now, this part of the LVOT is very leftward. This part of the LVOT, I'm sorry, RVOT is very rightward, and between them is a mix. Lead one sits somewhere here. Okay, so if you are here, lead one is going to be negative. If you are here, lead one is going to be positive. If you are in this half of the LVOT in the back, the septal half, you got more muscle between you and V1 and V2 compared to the free wall. Free wall is too close to V1 and V2, and all of that will have implications. What are the implications? Well, let's see. So the RVOT now, if we were to break it down, we would see that, again, transition makes a difference. Septal versus free wall makes a difference. Anterior versus posterior makes a difference. So what does that mean? So notice, for example, between those two distinctions, the one on the left is septal side of the RVOT, the one on the right is the free wall side of the RVOT. Where is that? We talked about it. So the septum, you can see the septal half and the free wall half. And then there is a zone 1, zone 2, zone 3, or site 1, site 2, site 3. Site 3 is more leftward, site 1 is less leftward. In other words, site 3 is more anterior, whereas site 1 is more posterior as far as lead 1 is concerned. And so when you get to site 3, where you're very, very close to lead 1, is going to be negative. Let me see if I can mark it here so you can see what I'm looking at. So this, for example, is very negative. It's very close to lead 1. This becomes very positive. And this is septal. Well, why is it septal? Look, the KRS is narrower than the free wall. The free wall side, wider KRS. Free wall side has notches. Look at the notches at the top of the KRS. Look at the notches, okay? RVOT doesn't, I mean, the septal side doesn't have that. The transition. The free wall side, I mean, the septal side transitions between V3 and V4. Well, look, this starts transitioning a little bit later than that. Look at V1, V2, V3. There are barely any R waves in them, right? Whereas this has a little bit more R waves than you see on the free wall side. So the transition is later on the free wall. The QRS is wider on the free wall. The QRS has more notches on the free wall, and the QRS is wider on the free wall. And then, you know, lead 1 then tells you if you're in site 1, site 2, or site 3, and that tells you whether you are very anterior in the RVOT or posterior. Well, how do you tell anterior, posterior? How do you translate that in catheter movement, catheter positioning? You do that by essentially opening the catheter up or closing it.
Please mute your microphone, please. Thank you. Sorry, Dr. Khaled, go
No
on.
worries. No worries. So essentially the way you tell the difference with the catheter, when you have the catheter in the RVO2 and you deflect it backwards, Okay, that's taking you towards site 1. When you open it forward, that's taking you towards site 3. I cannot tell you how important it is to use intracardiac echo when you're working in the RVOT. And that's something that it is important for most of these things, particularly when you're working with idiopathic VT. Idiopathic VT is extremely, dependent on intracardiac echo. Why? Because when you are working, you're working with valves, you're working with intracavitary structures, you're working with areas that have complex anatomy like the RVOT. When we do these things, we want to localize it quickly, safely, one spot, ablate, done. 30-minute case, 40-minute case, done. Okay. We do not want to ablate a lot. The more you ablate, the more you struggle, the higher the risk of complications. Okay. One thing I wanted to draw your attention to now as we were talking about the EKG and trying to figure out where to go, I want you to recognize what can happen sometimes between what the EKG you have in clinic, the EKG you have while you're doing stress testing, for example, and the EKG you have in the lab. This is the same exact PVC, but look at the transition and how different it can be. This is, in the clinic, it is a V3 transition, but when you get to the lab, it's a V4 transition. That makes a difference. Okay, it really makes a difference. Where did we ablate this? I ablated it in the septal side of the RVOT. So if I were to quiz people, or maybe not quiz them, but I would say it was this septal or free wall, that site right there with the little star on it. This is septal side of the RVOT. This is free wall side of the RVOT. And this is site 3, site 2, and site 1. So 3, 2, and 1. Okay. And so I would say this is septal site 3. Okay. This is a classification that Mark Josephson came up with, and a lot of people who learned in Josephson family teaching refer to. Not necessarily widely spread in books or anything like that, but it's published, but not everybody uses it. LVOT, again, the LVOT is a little far behind compared to the RVOT. And what does that mean? It means that we're going to have more R waves in V1 and V2 compared to RVOT. How do we tell we're in the LVOT? Well, we got more R waves. There are all sorts of criteria and ratios and things like that you can look at. They're helpful, but I think you have to look at the bigger picture sometimes, and being stuck on a particular number or something of that nature is not necessarily great. So you can look up these ratios and whatnot, but it's all about the R to S ratio. If it exceeds a certain threshold in V1 and V2, then you're probably dealing with an LVOT site of origin. So the key here is if you're transitioning after V3 RVOT, before V3 LVOT, but V3 is a problem. V3 is really difficult to make sense of. And so if the for V3 transition PVC, let's say, and again, when we talk about that transition concept, you also want to make sure that we understand that we're comparing that to sinus rhythm. Okay, so everybody's different. The heart lays in a different position in the chest, and everybody changes as we age, and so and there are really interesting reasons for that. But the transition is also important to look at from the perspective of comparison to sinus rhythm. So, for example, if you have a V3 transition, which we said is the conundrum, that's the one that is hard to tell. But if the transition in sinus rhythm is actually earlier than V3, so V3 transition in the PVC, but the transition in sinus rhythm is actually later, is earlier than that. So you're transitioning after sinus in the PVC after sinus, that's number one, and it's in V3. Well, that's always RVOT site of origin. So that's when they went back and looked, it was always from the RVOT, the successful ablation site. Now, if you are transitioning before sinus rhythm and you are transitioning in V3, okay, so sinus rhythm transitions in V4 or later, and you transition in V3, or the PVC transitions in V3, then you're looking at 71% chance it is coming from the LVOT. Not always true, okay? So it's 71%, not 100%. But if you transition before sinus, it's 100% RVOT, okay? So that takes care of a lot of the V3 transitions. Now, the problem is if you have PVC and sinus transitioning in V3, well, how do you tell the difference? And one of our fellows, when he was a medical, well, he was trying to remember, he was a medicine resident or something. When we were fellows, he came up with this V2 transition ratio, which is an interesting concept. Again, you don't necessarily need to remember numbers or anything like that, but he's comparing the proportion of R waves and S waves in V2 compared to between sinus and the PVC, trying to figure out if there is a particular ratio that would actually predict LVOT versus RVOT. And he found a cutoff of 0.6. If it is more than 0.6, then you got LVOT site of origin. Less than 0.6, it's RVOT. You don't have to remember that. It's nice to look at it. And that one was actually very sensitive and specific. What are the pitfalls? Well, when they did this, they obviously excluded patients with bundle branch block. Somebody with bundle branch block in sinus, well, how do you tell the difference there? That's difficult. So these things don't apply. If you're trying to compare sinus to PVC, it doesn't apply. And it excluded patients with cardiomyopathy, so essentially structural heart disease VT, which is not what we're talking about here. So this is not applicable to patients with structural heart disease. Well, what about in the LVOT? Where are we in the LVOT? Well, the LVOT is a very big structure. There is the right cusp, there's the left cusp, there's the non-coronary cusp, and then there is the commissures or the junctions between the two, between the right and the left coronary cusps. Very important. And so on and so forth. Well, there are some signature looks, okay? And this is one of my attendings when I was a fellow, David Lynn, he published this. Sometimes, you see things like that when you're in the left cusp, the M or the W pattern in V1. This is something he talked about in that paper. The things that are very classic and like not really disputable at all, for example, the QR pattern you would see in this area here between the aortic and the mitral valves. This is called the aortomitral continuity, this area right here. Okay. This area here would give you something that looks like this. It has a Q pattern in V1. And obviously it is on the mitral valve. We said anything on the mitral valve, anything that is on the mitral valve will be positive V1 through V6. We call that positive concordance. And that's why when we see a rhythm that is positive in V1 through V6, a white complex rhythm, we always say it's VT. It cannot be SVT. There's no SVT that activates the heart at the mitral annulus. Okay, the Purkinje system does not activate the heart beginning in the mitral annulus. It always activates the heart in the middle of the ventricle. It's never at the mitral annulus. So that is diagnostic for VT. And if it's negative concordance, where it's negative in all precordial leads, it's in the LV apex, and the conduction system doesn't go to the LV apex directly either. So these things are suggestive of VT for that reason. And then, so this is a characteristic morphology. It's a QR pattern. So it's something that looks like this in V1 and positive the rest of the precordial leads. The non-coronary cusp is really interesting. The non-coronary cusp, you can capture a ventricle in the non-coronary cusp. So it's not just atrium that you capture there. And the key here is the ratio between lead 3 and lead 2. Lead 3 will be a little less than lead 2. And the reason is it's slower. And it's also closer to lead 3, which is here. Okay. So lead 3 is is here. And so you're getting closer to lead 3, so you're going to have less R waves in lead 3. Okay, so these are important things. Now, when we start seeing this sort of 2 to 3 ratio, where 3 is lower than 2, we start thinking that we dropped low in the LVOT, dropped low towards the non-coronary cusp, dropped low towards the pariesin area, dropped low towards the posterior superior process of the left ventricle. We'll talk about, I'll show you. But we're dropping into the infraseptal aspect of the RVO of the LVOT, okay, when we start seeing this 2 to 3 ratio. If this is in something that has a later transition with this sort of 2 to 3 ratio, that means you're somewhere in the RVOT, but then you're not really at the pulmonic valve, you're coming down the RVOT. And when you come down the RVOT, you start getting closer to lead 3, and then you have less R waves in lead 3, but then lead 2 is more towards the left ventricle, so you still get big R waves in lead 2. So that happens also in the RVOT, but then you will have a much later transition, okay? Much later transition. I'm sorry if this gets confusing after a while, but these things are really important for doing this work. Other characteristic sites, the junction of the right and left cusps. And so we look at that with a slightly different eye. The junction of the right and left cusps would be somewhere, let me see if I find a better picture. We had a bit better one. We could look at it here, for example. This is a better section here. So it's this area here, the junction between the right and left coronary cusps. Okay, it's very important. A lot of the LVOT, PVCs, and VT come from that area. You got to know this very well. This area is can be a problem. Let me see. I have another. So this is also important. Let's see this in a Carter sound reconstruction. So this is the left cusp. Okay, it's the highest one. The right cusp is a little lower. Non-coronary cusp is the lowest. The junction between the two is right here. Okay, there are PVCs that come from the left cusp, there are PVCs that come from the right cusp, and there are PVCs that come from the junction. Well, the junction is very distinct. And also notice something. The junction of the right and left coronary cusps is right behind the middle of the septal aspect of the RVOT. A lot of these actually come from in between, and you have to ablate it from both sides. Okay, let's get back to what we were doing. Okay, now sometimes in the junction between the right and left coronary cusps, they noted that you could have late potentials in sinus. So look at this site, successful ablation site. Rupa Bala was also an attending, I trained with, and she wrote this. Look at this late potential, which I just covered with the arrow right here. Just telling you to look at it. That late potential is there in sinus rhythm. Interesting. Sometimes you actually see areas of slow conduction. It's very limited. It's just like one thing, and it's not really multiple late potentials and multiple morphologies and things like that. That makes it more of a structural heart disease issue. You can see the same potential on Cardo. You see that guy right there with the white arrow. Now, when you pace, you get a good pace map, okay? Like an excellent pace map. But at the same time, that pace map is giving you a long stem TKRs. When I actually am dealing with an idiopathic VT, if I think I'm dealing with an idiopathic VT, and I go anywhere in the area around the right-left junction or around the right cusp itself, and I capture any pace map, I don't care if the pace map is good or not. If I think it is an RVOT PVC or an LVOT PVC, or I think it's a right cusp PVC or a junction PVC, and I capture anything with the long stem TKRS, if it doesn't look like the PVC, I am still ablating it. And I will tell you 9 times out of 10, although the pace map was not great, although I could not do activation mapping on the PVC, if you're dealing with an idiopathic VT, what you think is idiopathic is you have one spot in there that gives you a long stem TKRS capture, burn it. It's an area of slow conduction. It is likely causing the arrhythmia you're dealing with, but you're just capturing it and exiting in a different direction than what the site of origin does when you're not there and pacing. You ablate it and literally it makes things go away. So that you're ablating without good pace map, you're ablating without adequate activation, but you're ablating based on understanding of the EKG and understanding of the pathophysiology of the area that you're working in. And that's really important. Sometimes you're not going to get the activation and the pace mapping and all these classic things, and again, we want to, and we talked about this last time, mapping systems are designed to think like an engineer. Okay. They don't think like a doctor. You got to think like a doctor, not like an engineer, not like a mapper who wants to see an excellent pace map and an early activation or one or the other or something. But you're a doctor. You understand based on the EKG where you're at and what can happen in this area and what you're looking for. And it does not have to satisfy the engineer. It just has to satisfy you. And so that's one of the things in EP. We need to stop thinking like engineers. We need to think like doctors. This is another concept we're going to talk about, the LV ostium, the opening of the left ventricle itself. The LV ostium is all of that ventricular tissue that surrounds the opening of the mitral valve, that surrounds the opening of the aortic valve too. And so the LV ostium is a very important concept. When you're ablating, you're not ablating the valve itself. You're ablating the muscle that is directly attached to the connective tissue of the valve. That muscle is the problem. It is irritated for some reason because of its connection to connective tissue. You got to understand sort of the relationships, and this is a very, very extensive anatomy class, the relationship between the left cusp and the non-coronary cusp, and what's between them, which is the membranous septum, and how thin that area is, and how that is directly related to the conduction system. The conduction system is right underneath it. And it pierces into the ventricle right directly next to the membranous septum. Now, in between the left cusp and the non-cusp, you also get another thin area, and that area I believe is called the posterior fibrous trigone or something like that. But also a very important area. We ablate a lot of atrial tachycardias from that area. Okay. And so, and you think about it, the left atrium is removed in this section, but the left atrium would literally is fit right exactly on it. And so left atrium is sort of taken to the side there. You can see the right atrium, and then the left atrium should be right in that cavity that has been removed. And so these things are extremely important. Understanding these anatomic relationships is extremely important. When you are on the mitral annulus, obviously you're right behind the circumflex. You get the LAD between the RVOT and the anterior wall of the left ventricle. And when you are in the left cusp, you are right under the bifurcation of the left main. Okay, you got to respect all of these structures. You have to look with intracardiac echo or use contrast or something to know where you're at. You can see the distance between the bottom of the left cusp and where the left main is. It's not a lot. It's about 1.5 centimeters or 2 centimeters, maybe at max. You got to be aware of where you're at so you don't cause too much trouble. One of the things that we need to talk about, maybe not a lot, but we need to at least introduce the concept of what's called the left ventricular summit. Let me see if I have a better. Okay, we'll go back to this, but let me explain on this what the left ventricular summit is. If you look at the left ventricle, the entire left ventricle is lined up. So the highest part of the ventricle, the top of the left ventricle, is this area here. Let me try to do this in a different color, maybe black. This area here. This area here is the top, the highest muscle in the left ventricle is in this area called the left ventricular summit. Essentially, it is the area that is under the left coronary cusp junction with the mitral valve towards the RVOT, and that area is really one of the hardest areas to work on. And the reason is, well, you have the bifurcation of the left main, you got fat between the bifurcation, and then you got tissue that you really cannot easily access. And so in this area, you're going to be dealing with multiple things. You're going to be dealing with different sites of origin. You got the RVOT that is not too far. You got the left cusp, which is not too far. You got the summit area, which is either here or here. So this is the LV summit. The LV summit, you can have sort of a leftward side and a rightward side. Now, they produce different things. So let's review the principles we talked about. Our VOT is going to have a slightly later transition. So it could be V3, could be V4, but you can see it here. We transitioned in V3. We're positive in the inferior leads. The left corner cusp is going to be positive in the inferior leads. We're still high up in the LVOT or in the ventricle, but you're going to see the transition is a little earlier in the left corner cusp. And then there is the aortomitral continuity, which, you know, would have this sort of QR pattern. I think this is more of a left cusp pace map. I would have expected this to look more like this in V1. And then you get the great cardiac vein. Where's the great cardiac vein? Well, let's talk about that a little bit. You guys all implant left ventricular leads, the coronary sinus. You enter the coronary sinus here, and this is the coronary sinus until you get to the valve of Usens, and then from here it's all great cardiac vein. Okay, so that's a big difference. Here there's muscle coating to the coronary sinus. Here there's no muscle coating. Once you get to this point, there's no muscle coating. You can actually perforate the great cardiac vein very easily. It's not easy to perforate the coronary sinus, but very easy to perforate the great cardiac vein and its tributaries. If you are in the great cardiac vein, or the side origin is in the great cardiac vein in this area, okay, that's the septal side of the LV summit, or no, I'm sorry, the lateral side of the LV summit. Here you are on the mitral valve, okay? Here you are on the mitral valve, that area. So what will you get? You get positive deflection in V1 all the way through, okay? And so that is characteristic. You're on the mitral valve. Oh, and I'm inferiorly directed too. Positive in lead 2 and lead 3. And I'm negative in lead 1. Why? Because I'm lateral. I actually crossed the plane of the LED and crossed the left cusp. I got to be lateral. And notice also something about this KRS here. It has delta waves. Okay. This KRS does not have delta waves. None of these three have delta waves, but this one has delta waves. Why? Because we're on the epicardium. When we are in the great cardiac vein, we're on the epicardium. Okay, and so how do you get there? Well, I showed you some of these, how to, navigate all the way around the great cardiac vein to get to that area. And these are really easy ablations, targeting this area and getting rid of those. You can do it from the endocardium. You can do it from the epicardium, which in this instance means going through the coronary venous system, not going through the epicardium itself. You don't need to do that. Or going into the pericardial cavity, you don't need to do that. In fact, if you did that, you wouldn't be able to get rid of it. Why? Fat. You have fat around the circumflex. Okay, let's see if we can. Yep. Okay, let's get rid of this. Okay. So the LVOT, especially when you get to this LV summit, this area closer to the left main becomes what we call the inaccessible area. And then the area that is closer to the mitral valve is more accessible and easier to actually ablate. Sometimes you have to ablate it from the left coronary cusp. And there are EKG criteria for the AVL to AVR ratio and what predicts the accessible versus the inaccessible area. And essentially what you're looking at is a ratio that is low. And if that ratio is low, as far as the AVL to AVR ratio, and you're probably dealing with something that is essentially closer to the septum. That's what that is trying to say. Look at the mean deflection index. Mean deflection index is something that we look at to tell if an arrhythmia is arising from the pericardium or the pericardial surface. And if you are arising from the pericardial surface, you have a higher mean deflection index. And that just, the mean deflection index is how much of the KRS is included in the first half of the KRS, which is from, the beginning of KRS to the highest deflection in the precordial leads. How much time? Did it take half the KRS to get there? More than half the KRS? If it takes more than 55, if it takes 55%, 54% of the KRS, or more than 50, I think the cutoff was 55, then you're probably dealing with something coming from the epicardium. And so those guys tend to have these sort of epicardial features. Let's see what that would look like in some of these. I'm not sure if these movies will play. Okay, they will not. But then again, you can see the catheter. So if we want to get rid of those, we go with the catheter all the way through the coronary sinus, all the way up to the distal great cardiac vein. You see that we have an arrhythmia, a PVC or VT that is actually positive in all the precordial leads. It's inferiorly directed, tells us we're on the mitral valve. Where on the mitral valve? Very, very, very top of the mitral valve. Why? Because we're still positive in leads 2 and 3, very positive. We go there, we see a very early signal on the pericardial surface as we are in the coronary sinus. And it's pretty early, and it's a pretty good pace map. Let's talk about this a little bit more and apply it to some other PVCs or VT. You can see the QR pattern in V1 in the AMC, the area in the aortomitral continuity. Aortomitral continuity is usually an endocardial PVC or endocardial VT when it happens. You can see a pace map of that relative to the PVC itself. You can see the aortomitral continuity was just a little different. At the junction of the right and left coronary cusps, you can see that we're getting something that is very characteristic. I forgot to actually mention that when we were talking about it. There's usually on the KRS in V1, there's usually some sort of a change in slope. Okay, here it's like a W pattern, but a lot of times just a change in slope in V1. It's very characteristic for the right-left junction. If you have something that looks like it could be coming from left cusp, right cusp, RVOT, I'm not sure. You see this sort of change in the slope. They call it notch on the downstroke of the KRS in V1. Very suggestive of the junction of the right and left coronary cusps. Why? I don't know. But that's the observation that has been made. If you are in the right coronary cusp, you start losing all of these details. You become really strict left bundle with a transition that is about V3, and that's as early as you can get in the right cusp most of the time. But you can see the difference between the R wave amplitude in lead 2 versus R wave amplitude in lead 3. Again, very characteristic look. Okay. So just again, doing the same exercise and going through special features, general rules, apply both, and then you will know what you're dealing with. This is another case. Okay, we're looking at something that is inferiorly directed, positive in leads 2 and 3. It's positive in lead 1. It is a left bundle tachycardia. PVC, VT, it doesn't matter, it's the same thing. And we see it transitioning, become negative to positive transition happens in V3. You see that happens before sinus rhythm. Sinus rhythm transitions in V4, V5. And so that we said V3 transition, if it happens before sinus, then probably 70% of the time we're dealing with something coming from the LVOT. If I were to guess, because of the look in lead 1, how positive it is, the slight difference in the R wave amplitude between leads 2 and 3, and and the fact that we transition in V3 ahead of sinus, I would expect this to be coming from the right coronary cusp. Let's look at another case. We're looking at something that looks like a an inferiorly directed PVC, sometimes superiorly directed PVC or VT. So we do see the alternation in the sort of axis. For the most part, they're negative deflections in the inferior leads. And you can see that when we are superiorly directed, we have something that looks almost positive all the way, almost all the way, not exactly, when it's superiorly directed. Now, you will notice also in the inferior leads, there is an initial R wave. You'll notice in the lateral leads that there is an initial Q wave. It's actually apparent in the inferior leads, but not so much in the lateral leads. And so that's important to notice. So when you see something like that, this is not exactly on the mitral annulus. Why? Because we have deep S waves as we go back. It's close to the mitral annulus, but as we go towards V6, it doesn't. It starts losing some of that R wave dominance, and then you start seeing more S waves. So it tells you it's off the mitral valve. So it's mid-ventricular, but closer to the mitral valve kind of thing. And so what is mid-ventricular closer to the mitral valve? You're looking at something that is probably more, towards the basal or the more valvular side of the posterior papillary muscle. Perhaps it could be the left posterior fascicle. And so then the question becomes, well, how do you tell the difference between fascicular, I think we have a slide for that, between fascicular and papillary muscle VT. And that's important. Fascicular VT will be narrower, papillary muscle VT would be wider. You have a typical right bundle in fascicular VT. You will have Q waves in lead 1 and AVL. Okay, so you will have in the lateral leads those Q waves in 1 and AVL. So they could be Qs, could be Rs, depending on what you're dealing with. Posterior medial versus anterolateral papillary muscle, or left anterior fascicle versus left posterior fascicle. And then you're going to have the small Q waves or are in the limb leads and leads 2 and 3. And so you get to look at that and you kind of try to apply it to what you're seeing and see if that helps you kind of tell the difference. And what I see here was more to me telling of probably something along the lines for the superiorly directed one. It helps. It probably is papillary muscle. Now let's look at more examples of those morphologies and things that present exceptions. Maybe they're not necessarily always along the lines of these rules. So look at a left coronary cusp pace map all the way to the right, and you can see you got sort of V3 transition there, and you're inferiorly directed and. Now the PVC itself in the left coronary cusp was actually not that early. It was actually positive throughout the precordium. When you look at this also in the right-left junction, you can see that you're also late. You look at the right coronary cusp, you see you're also sort of late. And so what we're trying to say here is sometimes the pace maps, even in a good spot, and I'm not saying this was the good spot here. What I'm trying to say is even in a good spot, sometimes the pace maps might not really be very helpful. And this gets us into this discussion about the spatial resolution of pace mapping versus activation mapping. Activation mapping has a much better spatial resolution compared to pace mapping. These are probably more advanced concepts for you know, these areas that are sort of between the mitral valve and the base of the left atrium, and are not necessarily, you know, a focus of what we're talking about today. It might be a little too out there. I want to show you this. This is a again, VT PVC kind of thing, and I think we've probably showed you guys this EKG before. But you got to be able to look at this and say, okay, where's the rhythm? The rhythm is probably biventricular pacing or something like that, based on the morphology of the paced QRS. But then there are PVCs, and the PVCs are inferiorly directed. They are positive in 2, negative in 3. Oh, that tells me right away. So I'm inferior direct coming from the outflow tract or something high up in the ventricle, but then 2 is higher than 3. That means I drop down into the zone of the right bundle, right cusp, non-cusp, right non-junction, his bundle, parahesian area, or the bottom of the RVOT or something of that nature. And you can see when you look at the transition, like, okay, well, that's sort of the X. Where's the transition? Transition is actually sort of V3, so it's earlier. It's probably not RVOT with V3 transition and this 2-to-3 ratio. This is something that's coming from somewhere near either the right cusp. Would be really lucky if you find this in the right cusp, or it could be even lower than that in the Parahesian area, particularly right Parahesian area, and that's a concern. Now, this person has a biventricular ICD, so, or biventricular device, so giving them heart block might not necessarily be the end of the world. Now let's look at this PVC and see the difference between leads 2 and 3. Again, it's the same ratio. 3 is a lot lower than 2. And this is showing 2 different PVCs. One of them was higher up in the RVOT. You had 2 and 3 upright. In the inferior, and the other one, which was the other blue ball, that was lower down in the RVOT, and that one was actually, you can see, it was negative in lead 3 compared to lead 2. Also, when you come down in the RVOT, you might start seeing a slightly later transition. And so you start seeing less R waves and more S waves in V2, V1 through V3 if you are off of the pulmonic valve. This is sort of ablating those 2 PVCs we saw. And one of them was, again, like I said, lower. I'm trying to, I think this was actually ablating in the LVOT, and it was probably more like at the junction of the right and left outflow tract, right and left coronary cusps. I don't see the particular characteristic transition, but that's sort of where it was ablated directly under the right cusp or right under the transition and or the junction. And you can see again the 2-to-3 ratio. That can be right cusp. And I think that's where that was ablated. Now, I think the second PVC was coming from the RVOT. That's the one that was ablated there. And I have shown you guys this before when, let me see if this slide shows it a little better. You can see the junction of the right and left coronary cusps here is, and again, this relationship is extremely important in the junction between the right and left coronary cusps and the RVOT, okay, and the pulmonic valve. They're right next to each other. If you ever see this on ultrasound, it's really amazing. They're very, very close. And a lot of times these PVCs have to be ablated from both sides. Sometimes you have a site of origin that is somewhere in the RVOT that just exits sometimes to the LVOT, sometimes exits to the RVOT. When you start seeing things like that, just be a little careful. Sometimes you can have structural heart disease. It's just not, apparent yet. All septal VTs, and the reason septal VTs are very difficult to manage is they have access to too many structures to exit. So they can exit in the RVOT, anywhere in the RVOT. They can exit in the LVOT under any cusp, and they can exit in the bottom towards the S, and they can exit towards the peplar, so they can exit. They're just very difficult to chase. But the exit sites map the site of origin for you, or site of where the scar is. Usually in very predictable spots, just hard to ablate. So parahasian origin, very important to realize that, very important to consent patients that way, very important to realize you're in a spot that could give you a heart block. And so what are the characteristics? You can have, again, remember we talked about the 2-to-3 ratio. It's very important. You get an R wave in lead one, monophasic R. You can get a monophasic, an R with a little s in lead one. V1 will give you a QS or QR. And you have early precordial transition, but the big thing is the ratio in leads 2 and 3, the R wave ratio. This was the one that we talked about at the very beginning, the K of the presentation. This is a case actually I did when I was a fellow, and it was a really interesting case. So you got to realize also, recognize the anatomy of the left ventricle as the left ventricle wraps up towards the membranous septum, towards the essentially the right atrium, which you do not see in this here, but essentially this part of the left ventricle, called the posterior superior process of the left ventricle, is it goes above the right ventricle. Why? Because the mitral valve is actually higher than the tricuspid valve. And so there is part of the left ventricle that is in direct contact with the right atrium. This part is in contact with the right atrium, not the left atrium. Okay. And the reason is the mitral valve is a little higher. So there's part of the septal side of the left ventricle that is actually interfacing with the right atrium. And that's where the slow pathway of the AV node is when you guys do slow pathway modifications. And that's where the ostium of the coronary sinus is behind that area. And when you ablate mid-septal pathways and all of that, if you think about all of these things, you will realize that it was this area that you're working with all that time. You can get PVCs in this area. And we had this case where we actually ablated those PVCs from the right atrium. Not from the left ventricle. We tried from the left ventricle, ablating under the nuncusp and all of that. And there was just a lot of, there was a lot of conduction system and thick tissue and all sort of stuff. And then we used cryo and we ablated it from the right atrium, which the right atrium is removed in here, as you don't see it, but the edge of this is essentially on the right atrium. So again, recognize when you are working with something that is not too far from the his, that patient can end up with heart block. You need to know. And the patient needs to know that. Talked about fascicular versus papillary muscle. Again, very classic example here. You can see the R's and the Q's. In the inferior lead, you see the R waves, little tiny R waves, and in the lateral leads, you see the very little Q waves. And these are very important because these things signify that the Purkinje system was involved in the initial activation of the ventricle versus papillary muscles, which do not necessarily utilize the Purkinje. They're close to Purkinje, but they don't necessarily utilize it. You can see a papillary muscle example on the left, and you can see a fascicular one on the right. Another structure to talk about, another niche application or just a special one, is the moderator band. The moderator band is essentially a tiny muscle band that exists in the right ventricle. It takes the right bundle from the basal septum and takes it all the way towards the RV apex, doesn't make it all the way to the apex, stops right before the apex and inserts into that area and carries the right bundle into towards the RV apex and essentially towards the anterior papillary muscle of the right ventricle. So the papillary muscle can close the valve first. And it creates there a very big structure. If you actually look at this on ultrasound, it is a very big chunk of meat, very big chunk of muscle here. It's the confluence of the anterior papillary muscle, moderator band, very easy to see with the intracardiac echo. And that area is highly arrhythmogenic. That area is full of Purkinje fibers. The right bundle is just basal and more septal from there. It's the easiest way to ablate the right bundle, to go to this area and pull back until you see the right bundle potential and get rid of it. If you have something coming from this area, it looks exactly like something we're all used to seeing. It looks exactly like left bundle branch block, because that's what left bundle branch block is. Left bundle doesn't work. You're activating the ventricle down the moderator band down the right bundle, and that's exactly what happens. So a moderator band VT looks very much like typical left bundle branch block. You can look at it and think, oh, this is SVT with aberration. You have to figure out if it's SVT or VT. And sometimes you you have to go back and use all sorts of other criteria to be able to tell the difference. But this is a very difficult structure to work with. Ablating the moderator band, there are multiple approaches to this. And when you do that, these arrhythmias arising from this area, they can actually come from anywhere around that structure. Remember, that structure is a three-dimensional structure. It's not one area, it's not one spot, it's not one direction. So you can be coming from this side, it can be coming from this side. I remember we had one when I was a fellow, is really coming from this side, sort of the like the superior-ish or free wall side of the moderator band is not coming from, the cavity side. It was coming from the other side. And if we didn't put the catheter there, nothing, I mean, we ablated and tried everything, and nothing happened until we actually got into that spot. Idiopathic VT, if you are in the right spot, it goes away very, very, very quickly. Okay, let's get rid of that. This is one of those things that cannot be handled without intracardiac echo. You really need intracardiac echo to be able to do this. Okay, is this? Yeah, okay. So anyway, sorry, this was too long and exhaustive. Now, when you're in the right spot, what do you use? I mean, I use usually 40 watts of power, irrigated catheter, something like a Q dot or something of that nature. It's totally fine. You got to know your contact force. You have to always remember that, or realize that you can cause a lot of damage if in a normal heart. Okay. So a normal muscle, you can actually ablate and perforate very easily. Okay. Even in the ventricle. Remember what you're dropping with 40 watts and whatnot. That's a lot of power. I'm not saying use less power. No, use a lot of power in the right spot, and you will only have to use it for a minute and we're done. But if you're not in the right spot, you're going to ablate a lot, high power. You might not notice your contact force. You start digging into muscle. Next thing, you find yourself outside of the heart. It's not hard to perforate a normal ventricle while delivering RF. Especially stim pops, they make it very helpful. It's almost like explosions. Well, there are explosions. It is hard to perforate scar. And so if you're dealing with an idiopathic VT, you gotta know where you're at. You gotta know your contact force. You gotta be in the right spot. And then you ablate, and then you don't ablate much, and you're done, and you don't cause problems. Otherwise, that can be a problem. I'm not an advocate of just using low power and trying to, again, remember, you can cause edema and then it becomes really hard to ablate through that. So those are the things you gotta be aware of. As far as PFA, I don't know that it's necessarily, better to use PFA for an idiopathic VT. I don't think you can use PFA in the right coronary cusp or the left coronary cusp. I would not do that. I mean, you're going to be using either a Farah or FaraWave or something like that. Those are two big catheters. Do not use those around the ostium of a coronary, especially like the left main or the right coronary ostium or something like that. Don't do that. You can use it in the RVOT. I've used a fair for RVOT PVCs. It's pretty, if you know where to be, it is pretty, it's a pretty easy ablation. They don't have really good mapping capabilities, but it's a pretty easy ablation. And I used RF, so I don't think PFA is really necessary for those types of applications. I think this is an RF primarily type application. Now, structural heart disease, you could say that there is an advantage to using PFA. We're not entirely all sure that that is the case, but I would stick to RF for now. I think we pretty much covered the topic. If you guys have any questions, I'm more than happy to take them. Sorry, it took too long.
Thank you, Dr. Khaled. It was a very, very interesting lecture as usual, and I think, yeah, yeah, it was it covered the whole subject, especially the localization of different localization, ECG localization of idiopathic VT. If any one of the has a question, don't hesitate to ask.
May I ask a question?
Yes. Who?
I'm Ahmed Mohammed from Germany.
Hello. Yes,
Hello.
you can. You
Hello
can.
to Khaled. Thank you very
Yes.
much for the lecture.
Sure.
Very informative. I would like to ask you about some questions about the techniques you use to get in the coronary sinus and navigate through the different branches. Do you go with a wire and then sheath and then a mapping catheter,
No.
or
No,
you just
not
map
necessarily.
with the mapping catheter directly?
Not necessary at all. If you have a contact force catheter, it's the best thing ever. For that, you have to, in your head, imagine the course of the coronary sinus. You gotta realize that you're going to enter the coronary sinus with a curve, right? So
Mm-hmm.
you're going in, let's say, with your with your D curve. At some point, after you get through the proximal third, the coronary sinus, you have to reverse your curve, right? Because you're rotating in the other direction. Contact force is extremely important there because if you see high contact force, don't push, pull back and adjust your angle a little bit. It is actually extremely easy to navigate the coronary sinus with an ablation catheter. Extremely easy. You got to have contact force, and I do it without fluoroscopy at all. Not at all. Just use the mapping system and the contact force and your understanding and sort of prediction of the shape of the coronary sinus. You see
Do you use a
force.
steerable sheath or a normal sheath?
No, you don't need a sheath at all. I actually think using a sheath there is you're just asking for trouble. I think you're giving yourself the ability to put a lot of force on the wall. I think the sheath actually makes it harder to maneuver because it commits you in one direction or another. I know a lot of folks who actually use an Agilis in the coronary sinus. I can tell you it really is not necessary at all. And the softer and the smaller the catheter is, and the more compliant and the less forceful, the easier it is to navigate the coronary sinus. At least in my experience, it's easier to go in with the catheter directly.
Also in the metricardiac vein, so with this difficult
Yeah,
angle.
cardiac is very difficult. Middle cardiac is really difficult to get to because and that might be a situation where the sheath could be helpful, but because you don't have a lot of bearing in the coronary sinus, you have nothing to stand on in the coronary sinus. You barely get into the ostium, and then you have to turn and go anterior. And so I've done it before also without a sheath. Um, Sometimes you can have a sheath sort of sitting in the IVC and find your way. And as soon as you get into the ostium of the great cardiac vein, you can bring the sheath in and then go down. I sometimes I used to. I don't use fluoroscopy for these anymore. When I used to use fluoroscopy, I used to inject contrast through the tip of the ablation catheter, and that would show you sort of the direction you need to go. into the middle cardiac vein. I have to say that the middle cardiac vein arrhythmias are, they're not very common, but also when they happen, in my experience, a lot of them are actually structural heart disease associated VTs. So it's essentially epicardial inferior scar and that kind of thing that you're dealing with. The true idiopathic middle cardiac vein PVCs or VT are extremely, actually, in my opinion, extremely rare. Most of the time, it is structural heart disease associated, just coming from the epicardium in that area. And you'll go in there and you'll find really good pace maps, and you can ablate there too. It's not going to get rid of the problem, though. Is the scar is a little bigger than what you can access through the middle cardiac vein.
Yeah. Yes. Does this apply for RVOT?
I'm sorry, say that again.
Does this apply for outflow tract arrhythmias also? Do you go there without sheath? Because I
Yes.
found that posterior superior aspect for right ventricular outflow tract is sometimes also difficult to
Oh, I
get
see what
there.
you're saying. Yeah, so I usually use when I go up the aorta, when I go into the RVOT, I usually use a sheath, but I use it just to make it easier to advance the catheter and pull it back. I don't take the sheath all the way up to the RVOT. I would actually say don't do that because sometimes the catheter just drops with breathing, things like that. And if you have a sheath, it's just a lot of force that you can be applying. And so if I take a sheath up there, I was taught to keep the sheath right at the tricuspid valve. Okay, so the sheath just makes it easier for you to maneuver the catheter a little bit, advance, whatnot, clot counter. The sheath holds you in place a little bit. I would absolutely advise you not to put a sheath into the RVOT. Is it,
Oh,
can it be more helpful to manipulate? Yes. If you slip or something happens while you're doing that, it's very high risk for perforation in the RVOT.
okay. Which sheath do you use? SL, just normal sheath, or
I actually, well, I use an Agilus sheath, honestly, when I go retrograde or when I go, and I use it again just to minimize scraping of the aortic arch and that kind of thing. So when I'm advancing the catheter, I'm not actually pushing the catheter up into the aortic arch and pushing down from the aortic arch towards the heart. And so it's better to just be encased in something. You can certainly use an SL1 or an SL0 or something of that nature.
which curve do you use when you use a Agilis? M or L?
Oh, like which curve on the edges? I usually use a medium or a large, but honestly, I'm not using the deflection of the Agilus. I'm using it just because it
Okay.
has really good support properties, and the catheter maneuvers through it very nicely. And so I rarely deflect the Agilus when I'm dealing with the RVOT or the LVOT. I just have it there for support. If I'm in the coronary sinus, I don't want a sheath in there at all. Now, where I use a sheath and I will use its deflection all the time is when I'm dealing with the moderator band or when I'm dealing with the capillary muscles in the RV. These structures are really hard. These curves can be complex, and the reach is too long for the ablation catheter to make it. You really need a sheath going with you into the RV, not necessarily deep into the RV. Again, I don't recommend taking a sheath towards the RV apex. It's one of the easiest spots on the heart to perforate. I leave the sheath sort of in the proximal RV and just have it give me stability and deflect up and down a little bit so I can be in the right spot. And then I use the catheter curve.
And which catheter curve do you choose mostly?
For which I mean usually I'm going
Oh,
with for an idiopathic VT I'm usually using a DF.
yeah.
I mean yeah. I mean for an idiopathic VT, yes.
Do you use the base mapping a lot or
Do I use what? I'm sorry, I didn't hear.
pace mapping?
Pace map, yeah, pace mapping is helpful when you don't have PVCs. That's the only thing you can go by. If you have a lot of PVCs, then there's no point in using pace mapping. Use activation mapping. It's better. Pace mapping is less accurate in the RVOT, better in the LVOT. And so if you're in the RVOT and you use pace mapping, things have to be identical, like not close, identical. Okay.
Mhm.
And even then, it's not that great.
Okay, thank you.
Of course.
Okay, I have a couple of questions for you, Dr. Khaled. What's the highest energy you go for RF ablation in the RV and RVOT or RV proper, and in the LVOT?
I never go above 40 watts. I usually just start at 40 watts. But
Even in the RV?
yes,
Okay,
if you're in the right spot, you really don't need more than 40 watts.
okay,
I mean, if you think you need more than 40 watts, in my opinion, then we're not on the right spot.
okay.
It's not that it shouldn't be that deep.
Mm,
Contact force can be a problem in the RV.
mm,
And that's why I said, I like to have a sheath by the tricuspid valve so
mhm,
I can, kind of have something to hold me in place a little bit and then use the catheter curve to get there.
mm,
But I really, I've had when I was very young, I had a lady that had a perforation on the free wall of the RVOT. It was pretty
mm,
easy. It's just a steam pop. And so if you start going above, 40 watts, and you're more likely to have a steam pop. But again, I would say for idiopathic VTs, they're really, really, they're again, remember, they're not tied to scar. There is no, it's very superficial. It's a small group of cells. If you're in the right spot, you really don't need more than 40 watts, in my opinion, at
mm,
all. If you need more, maybe the location needs some adjustment. Maybe the contact force is not great. In the RVOT in particular, there is the septal side of the RVOT. You have to really bend the catheter a
yeah.
lot to get there, and that's what a sheath helps you do.
Mm,
Um, and again, not going into the RVOT, but sort of by the tricuspid valve, and then you really have to use a lot of deflection on the catheter.
mm,
And sometimes it doesn't want to stay around that curve. Sometimes it just
yes.
breathing, that kind of
Just
thing. It
slips. Yeah,
keeps slipping down.
yeah.
So when it keeps slipping down, I mean, I would just look with intracardiac echo, try to make sure you go all the way towards the valve,
Mm-hmm.
the pulmonic valve,
Pulmonary.
and and try to get contact there right at the
Mm,
valve, right below the valve, that area. They usually come, like I said, from areas where you have connective tissue. So it's usually at the valve level, at the pulmonic
mm,
valve annulus, not below it. For idiopathic
mm,
VTs, when you start getting stuff below the pulmonic valve, you
mm,
actually start thinking more of RV dysplasia or septal cardiomyopathy or something of that sort.
okay. Okay.
So,
Mm,
yeah, this is where you start getting the stuff that needs a lot of power and a lot of
mm,
that stuff because you're ablating the septum essentially. It's all
mm,
coming from deep in the septum. So you might actually suppress it with ablation, keeps coming back, that type of thing. You need to use more power. You're probably ablating a septal VT that is exiting in the RVOT. It
mm,
does that.
mhm,
Whereas the idiopathic ones, they're usually by the valve. If you're in the right spot, 40 watts is plenty. And
mhm.
they usually go away.
Okay. So if you're mapping an idiopathic RVOT PVC, okay, and you have a large area of earliest activation, what does that mean?
Yeah. So that's interesting. So anytime
Mm,
you see a wide area of early
yes.
activation, it tells you probably are not seeing the earliest. It's one of two things, yeah, or your annotation is not correct. So you have somebody who's annotating far field and
Mm,
near field to the same timing, so you get a very big area. Usually it means also that you're just not really getting the earliest. So let's say
mm,
if I have a wide area and the earliest is 20 milliseconds pre-QRS, well,
mm,
that's not the earliest. And the
yes.
area is very big because it's probably coming from the from the LVOT, okay? And I'm seeing
Yes.
active activation of the RVOT. So then I
Mm,
got to go to the to the LVOT and see if
mm,
there is earlier activation there.
mm,
Now I see something that is 30, 35
mm,
pre-QRS. Now I'm convinced.
mm,
So anytime you see very wide area, it usually means it's passive secondary conduction.
Yeah. Okay. But if you will go to the left side and it's late, what's the other option?
If you go to the left side and it's late,
Mm,
then what I would do is then when it's a wide area, we're talking about like cardo red zone, right? I mean,
mm,
what I do is I tell the mappers, I tell them narrow your red zone, narrow
yeah.
your spectrum.
Mm,
So
mm,
they push their window
mm,
to make the early, and instead of anything that is 0 to 30,
mm,
it's all red.
mm.
I want them to make it only 20 to 30.
Yeah, okay.
So then it becomes a much smaller area,
Mm.
and then sometimes you just have to go through all the points they have and
Yes.
see what is wrong. Sometimes one point can make it look like that,
Yes.
one wrong annotation,
Mm.
that kind of thing. And quite honestly, I just don't look at their colors and numbers and that kind of thing much anymore. Sometimes they're very helpful. They tell, well, I saw something here, something, you're not looking, they
Mm.
alert you to it. But I think really where it works really well for these things is you look at the EKG, you sort of know where you need to be. You put the
Mm.
catheter there. You got to know, I'm not mapping the entire RVOT. I know
Yes.
there's a septal RVOT, it's septal side 3. I'm going
Mm.
there. I'm looking at intracardiac. I'm not mapping even below the, I'm going to be
Mm.
right on the valve. I'm getting a couple points there. When I see one that looks like a good signal, I'm ablating it and we're done. That's it.
Okay. Yeah. Okay. Yes. That's okay. Thank you, Dr. Khaled.
Can I have
Is there any other
some?
questions? Mhm.
I still have two questions.
Okay. Dr. Ahmed?
Yes, please.
Okay, go ahead.
What would be your ablation index?
So I mean, for VT, for applications of VT, I usually like to see something like 600, 500, 600. And I typically don't really care too much about the index. I'm looking more at the duration of the lesion.
Yes.
I'm looking at, I mean, if I'm in a good spot, I'm ablating for at least 2 to 3 minutes. If I got confirmation it's gone, it's done, I'm ablating for at least 2, 3 minutes in that spot. And then I'm going to also sort of reinforce the area around it, just a millimeter this way, a little millimeter that way, put more applications there, at least 30 to 40 seconds in each spot. The ablation index, I think, is very helpful in the atrium. I don't know that is super helpful in the ventricle. I just don't use it very much in the ventricle. I look at the signals and I look at the response I'm getting from tissue. If the PVC goes away, then I'm definitely staying here for 2, 3 minutes. If the PVC doesn't go away and the signal goes away, I know I'm not in the right spot. I'm gonna go somewhere else.
If you stay 3 minutes in the same point, you will get a very high ablation index, right?
Yeah, it'd be really high. I mean, that's why I don't even look at it. If I'm in a spot and I ablate it and the PVC completely went away or something as soon as I came on RF, I'm definitely doing at least 2 minutes in that area. At least 2 minutes.
Continuously?
Hmm?
Yes.
Continuously?
Continuously, yeah. I'm talking about
Yes.
continuous lesions. Yeah.
Uninterrupted.
Yeah. 2 minutes, just to do
Yes.
2 minutes. Now, you have to make sure also you're not doing this with a very low impedance, for example. These are the things that people, I think, mistakes that sometimes are made and they create problems. So I'm not going to deliver a lesion for 2 minutes if my opening impedance is 80 ohms. That's wrong. You shouldn't do that. And so you should not have your people be, put in too many ground in patches or putting them too close to the heart. You're going to have a very low impedance. You cannot deliver lesions for a long time. You can't. You'll get a steam pop right away. Okay.
Yeah.
That takes away your ability to deliver long lesions. You want an opening impedance that is in the range of 110, 120, 130, something of that nature. If you start getting that, you can actually deliver power for an extended period of time. Make sure your contact force, you have a contact force catheter, not to make sure that you're in contact, but to actually make sure your contact force is not too high. Okay. So you can't deliver a lesion for 2 minutes if your contact force is 35. That's too much. Okay. That's too much. I mean, I would not do that. You're going to be able to deliver a short lesion and get out. The ablation index looks really good, but we know RF is very time dependent. If you're able to deliver a lesion for 2 minutes, it's so much better than higher powered or higher index lesion that only lasts 20, 30 seconds. Okay. And so which one is better? The one where you were able to deliver power for an extended period of time. In fact, there's really good data for that. Well, if your impedance is low, you're going to have a steam pop before you can finish ablating. Okay, I see people doing this a lot. That's really crazy. It's just like steam pop, steam pop, steam, because your opening impedance is low. So make sure don't put ablation, don't put ground in patches near the heart. Okay, put them on the legs. Okay, if you have two, well, look at your opening impedance before you start ablating. If it's low, 90, don't ablate with an opening impedance of 90. Disconnect one of the patches.
And then you enforce your lesion with surrounding points.
Yeah, I mean, you want to reinforce it a little bit, put an extra application in each direction. And I wouldn't do just one point and run.
Great.
Okay.
Thank you, Dr. Khaled.
No,
Very helpful.
Any other questions? Well, thank you so much, Dr. Khaled, for just a great presentation. I really enjoyed it. And I think everyone enjoyed it. And I think we kept you up. I don't think you're at not you're in the evening in at the United States, right?
behind you.
Yeah. Okay. It's the morning.
behind you. احنا اللي سهرناكم. معلش.
لا ما فيش أي حاجة. Thank you so much, Dr. Khaled, for a
لا،
great
إيه.
presentation. Okay.
Very
Dr.
happy.
Khaled.
Have a good day. Okay.
No
Bye.
problem.
Bye. Bye.
Thank you.
انت مؤذي 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 بس عسل.